reflex is laryngospasm. It is sustained and complete reflex glottic closure, which is involuntary in nature. It happens whenever any foreign material comes in contact with the vocal cord, or it can also happen to any poorly timed noxious stimulus like pain from incision and venipuncture in light plane of anesthesia. Before proceeding with the management, it is essential to understand the mechanism behind it. Our glottic and periglottic area is rich in sensory receptors, and the highest density of these receptors are present in the laryngeal surface of the glottis. So, whenever there is any chemical, thermal, mechanical, or local stimulus, it stimulates sensory fibers which ascend via vagus nerve, via internal branch of the superior laryngeal nerve, and leads to motor response by three muscles which are adductors of the vocal cord. And here the vocal cord acts as a shutter. But is that the only mechanism? No. What happens above the level of vocal cord? There is wall valve effect, which is created by closure of the false vocal cord and by the approximation of the soft tissues of the laryngeal inlet, extending from the hyoid bone to thyroid cartilage with the help of the contraction of the extrinsic muscle of the larynx, leads to closure of the laryngeal inlet. In totalo, the base of the epiglottis will move posteriorly, false vocal cord will contract, true vocal cord will act as a shutter, and eriepiglottic arytenoids move forward and tilt back. Risk factor can be categorized into patient associated, anesthesia related, and surgery related. In anesthesia related factor, whenever we are doing any procedure in insufficient depth of anesthesia, whether it's laryngoscopy, taking IV cannula in pediatric patients, these all things lead to laryngospasm. Any inhalational agent which is pungent can lead to laryngospasm in awake patient as well as patients being induced with inhalational agents. Sodium thiopentone does not blunt airway response, hence leads to laryngospasm more in comparison to other IV agents. Ketamine-induced secretions predispose to laryngospasm. When it comes to laryngeal mask airway and ETT, the chances of laryngospasm with LMAs are more on induction, and ETT, since it's a noxious stimulus itself, so more chances of laryngospasm on extubation. In patient-related factor, any pediatric patient, owing to their different airway anatomy than adult, and any children with airway anomalies are more prone for laryngospasm. Any patient with reactive airway, owing to sensitization of the efferent pathway from bronchus, lead to more chances of laryngospasm. Is any airway surgery and any surgery with chances of vagal stimulation, like genitourinary and gynecology surgery, these patients are more prone for laryngospasm in light plane of anesthesia. Presentation of laryngospasm can vary from inspiratory stridor to silenced chest, along with intercostal retractions, tracheal tug, paradoxical breathing, desaturation, bradycardia, and cyanosis in later stages. In complete laryngospasm, the laryngeal inlet is completely closed, whereas in partial laryngospasm, the posterior part of the vocal cord is still opened up. So, because of the Bernoulli effect through this narrowed airway, the velocity of airflow is very high, which leads to inspiratory stridor. And it can be very well confused with upper airway obstruction, which usually happen after emergence from anesthesia, immediately after extubation. Since in complete laryngospasm, there is no entry, no breath sound, the chances of hypoxia and bradycardia to ensue is very fast. Whereas in partial laryngospasm, hypoxia and bradycardia happens late. There will be EtCO2 in partial laryngospasm as there is airflow, but in complete laryngospasm, there will be no EtCO2. In our day-to-day practice, there are some possible strategies to prevent laryngospasm. When you recognize a patient which is prone to laryngospasm, an experienced anesthetist should perform laryngoscopy. Anticholinergic pre-medications like glycopyrrolate and atropine reduces secretion, hence chances of laryngospasm. Sedative pre-medications like benzodiazepine and fentanyl reduces cough and blunt airway reflexes, Hence, it also prevents laryngospasm. Propofol induction is always better than inhalational and other IV agent as it blunt airway responses very well. Whenever you are doing any IV cannulation, airway instrumentation, and surgical manipulation, especially in pediatric children, pediatric age group, deep plane of anesthesia is essential to do these procedures. The maximum chance of laryngospasm is during emergence from anesthesia, and especially during stage 2 of anesthesia, which is excitatory phase of anesthesia. Poorly managed extubation may provoke laryngospasm as ET2 is a noxious stimulus. But in modern anesthesia practice with balanced anesthesia, stage 2 is rarely seen, but the excitement and uncontrolled behavior are more likely to ensue from awake extubation if vigorous attempts of suctioning, physical stimulation, and loud verbal command precede removal of ET2. So it is always advisable to extubate in deep plane or to do fully awake extubation with no touch technique. During extubation, positive pressure is given, which will reduce the tone of adductor muscles, as well as it will pull up the secretions up and induce an artificial cuff, which reduces the chances of laryngospasm. Apart from these, intravenous lignocaine and intravenous magnesium sulfate has also been implemented in the prevention of laryngospasm. So whenever there is any desaturation during emergence period, the first response of every person is to give positive pressure. But it should not be given in laryngospasm. It may help in partial laryngospasm as there is minimal air entry is still there, but partial laryngospasm will eventually land up into complete laryngospasm. So whenever there are adductor vocal cord, the pressure above vocal cord is very high. It's 140 millimeters of mercury and 190 centimeters of water. And the below the vocal cord, the pressure is 30 millimeters of mercury. Whereas our anesthesia machines have 40 centimeters of water maximum limit, APL valve have 70 centimeters of maximum limit. So when we try to give positive pressure in burst with these pressures, it is not possible to overcome the adduction of vocal cord. Rather, it will further distend the pyriform fossa, and the aryepiglottic folds are pressed more firmly against each other, lead to wall valve effect, airway closure, and gastric distension. So after recognition, you should call for help, remove any stimulus if possible, which is not possible in most of the scenario as the jaw is tight. If it is possible, then you can insert oral or nasopharyngeal airway, give jaw thrust, and CPAP with 100% oxygen. Whenever you are giving jaw thrust, the pressure is transmitted through geniohyoid muscle to the hyoid bone and hyoepiglottic ligament. They lead to supraglottic. With this, the supraglottic tissue is pulled away and laryngeal passage is reopened. After this maneuver, if it doesn't resolve, you can give Larson's maneuver, where you place the middle finger of each hand in the laryngospasm notch between the posterior border of the mandible and mastoid process. Difficult Airway Society guideline has also recommended Larson maneuver before proceeding with pharmacological interventions. After this, you can give propofol 0.25 milligram to 0.8 milligram per kg. Succinylcholine as low as 0.1 milligram per kg IV dose is effective, but it can be given in higher doses also. Before giving succinylcholine, it is always wise to give atropine because already the patient is in hypoxia, bradycardia, and scoline causes more myocardial damage in these patients. If IV line is not available, then intralingual, intramuscular, or intraosseous doses of scoline should be implemented in this scenario. Other maneuver which can help in this is gentle pressure in midline of the thorax to overcome a pressure of 30 millimeter of mercury below vocal cord. In this case, you have to press with the palm of your hand with a force half of that required for CPR to 20 to 25 times in per minute to expel the trapped air inside the thorax and lead to unidirectional opening of the vocal cord. If these all maneuvers fail, then you have to go with invasive airway. Hypoxia, negative pressure, pulmonary edema,